In LMIC, when you see any patient, you always treat a family, not a single patient. The whole family comes into the hospital. So you have all the parents, grandparents. For a delivery, you will have 10 or 15 people waiting outside.
Wow, okay.
So this is the way our hospitals work. You need to involve the families in all the decision making.
Dr. Anuradha Pichumani is an award-winning, distinguished obstetrician and gynaecologist, an executive director and co-founder of 2 hospitals in the Tamil Nadu region in India. She has extensive expertise in healthcare quality, patient safety and person-centred care. Over the last 30 years, through her leadership and management skills, she has trained and implemented patient safety standards in public and private healthcare organisations, utilising implementation science and healthcare transformation in low and middle-income countries. My name is Juanita Guidera, a Programme Manager with National Quality and Patient Safety in the Health Service Executive in Ireland, and it's a pleasure to welcome Dr. Anu as our guest on the Walk and Talk Improvement podcast. So Dr. Anu, you are most welcome.
Thank you, Anita. Truly excited to be part of this conversation, and thanks to HSE and to you for inviting me.
It's an absolute pleasure. And today we're going to talk about learning health systems in low and middle income countries. And there's obviously a lot of learning that we can take from this within our healthcare system in Ireland as well. So we might just start off with a question. What does a learning health system mean to you, and especially in a rural secondary care hospital?
Yeah, thank you for that. As a doctor, I started out as a clinician. That was 33 years ago. And so I've been working with the patient care, and I feel every patient experience is an opportunity for you to learn and improve. That's how I started out working with the patients. When we started thinking about the global best practices, we started adopting them to our own local context so that we make the patient care more safe. So learning health system is evolving organization where you start getting various inputs and then you try to learn from them and then you adapt and evolve over the years. So healthcare systems across the world have so many challenges now because it's too complex and we need to deliver safe and quality care in a resource constrained settings. And so learning health system helps us to address these type of challenges. So it helps you to be more adaptable. It helps you to continuously learn from the data what is available. And again, it helps you to understand the context, what is happening. So for a rural hospital like ours, this is very important because with low resource settings, you need to understand what we can do with the resources, how to evolve the hospital over the years. And our hospital, we cater mainly to the rural and semi-urban population. And so we need to start listening to the feedback of the nurses for the patients, getting the ideas or feedback from them. And it's about learning each and every day. So when you start implementing these ideas, these quality improvement initiatives, you will see how best we can adapt it. And that's how we have started evolving as a learning health system. So this is more of a mindset. So you need to understand, you have to develop the culture so that you have a proper learning health system for you to move it forward.
Okay. And tell me just a little bit, just for people listening, you talked about your hospital being a rural hospital. What sort of population do you serve? And could you tell us a little bit about that hospital?
Yes, I and my husband together, we started the hospital, which is called Sri Ranga Hospital. It is in Chengalpet. It is in the place called Tamil Nadu, which is the southernmost part of India. And we cater mainly to the rural and semi-urban population here. And it has been a great learning for us because we started out as a very small hospital, where it's a 2-bedded unit. And now it has evolved into a multi-specialty hospital over the last 3 decades. We have various consultants, various specialties within the organization. We cater to chronic diseases. We cater to acute emergencies. We cater to obstetrics, surgical care, medical care. So all these have to be taken care of. So that's how we started evolving all these years. The first 10 years, we started building up from the ground level. We had to train our people and we needed to understand the practices which will help us to move forward. And so we had to standardize all the processes. So this helps you to move it forward as a learning health system. So the first thing that I started doing is to have a standardization of processes across our departments. So this helped you to run the organization and make it more safe. And then we started adopting various practices. We started contextualizing own patient safety metrics. Then we started training our people. So to understand the data, and with the data, what we need to move it forward. So these are some of the ways where with our own background of the organization, we had to move it as a learning health system. So this helped you to start learning. I can give you some examples. We started getting the WHO safe childbirth checklist. So we had to adapt it from the US, so from the R&D labs. So we had to include our own local practices because availability of blood is an issue in all these type of small hospitals. So any quality improvement initiative has to be made context specific. That is very important when we think about all these type of small hospitals, specifically in LMIC.
Yeah. We've had that conversation that sometimes there's a perception that the learning health systems, they're only for the larger academic hospitals. Your hospital obviously started off as a rural hospital. You said it started off as small and it's been growing over that period of time. What made you focus on a learning health system? Why was it so important to you?
It is very important because you need to have that culture of learning. Part is the most difficult part to get on in any organization. So getting the culture to help you to set the systems up, to make your team work towards learning, that is the most difficult part. When you get that, and you need the top leadership's commitment to do that. I was always interested in learning, getting new ideas, new ways of taking it forward. We started working as a team. So that's how I started creating a culture here. We had so much of challenges at the beginning because when you think about a LMIC, the hierarchical system is completely different from what you see in the other countries. So here, the top leadership, specifically in private hospitals, they are more accountable for running the organization.
Yes.
The stakeholders, the frontline workers, they don't take up that much of accountability. This hierarchical model creates various problems. So you will have missed opportunities for learning because they don't open up. And again, the adaptation becomes very slow because the ideas moving down the hierarchy stagnates in between. So we address this by flattening out this whole hierarchy. We always included each and every person in all our committee meetings. We started including quality meetings so that we'll be able to make them understand what is really needed to improve on patient safety and quality. So in that way, the importance was given to the staff and we were able to get that feedback. This helped us to evolve into a learning health system.
It's interesting that piece about hierarchy comes up even within our own system where you think you would have a relatively flat structure, but hierarchy, I think, in medicine in general is a known challenge. Obviously necessary at times, but there are other times when it's really essential to think about what benefit is it adding. What sort of conversations did you have with staff to help them realize that actually we do want to hear what you have to say? It's not tokenistic, that this is really important.
Yes, that is most important because having your team come together and start working as a unit, that changes the whole culture. So the first thing is making them understand whatever practices we are going to implement. We always ask their ideas. We do it as a co-designing, co-production, where we get their feedback, be it the doctors or the nurses working in the department. So we started including their ideas so that the compliance to any new change is better.
Okay.
So the behavioral changes, what changes we have to do in improving the quality and safety. As you know, any behavioral change is always a challenge. So be it your own children or be it your staff, the way we started making them understand why it is essential for them to understand how to improve it, what is the data they have to collect, how do they analyze the data, and how do they present it. So each and every department staff, the frontline workers started presenting their own data. And they started taking an accountability of how to improve the data in their own department. That started the change. And so every project had frontline workers as the most important person. Since we were running our own organization, there's top leadership and the management completely supports me. So that's how the top leadership commitment is very essential when we start doing these type of things. Now I see our own staff telling us, why did this happen? How can we change it? And they give you better ideas than what you have. So giving them importance and giving some recognition to the staff, all this matters. And this reward and recognition is very important. Taking care of their own ideas, getting their ideas, including in your own design, implementing it as soon as they say something. So these are things which help you to keep one team together. So I have employees who have worked more than 25 years, 30 years, who are still with our organization now. So we have created them as champions for each department. We try to move on with them, create an environment which is very conducive for them to work so that they are able to understand and move it forward.
Yeah, that is really important. Retention is so important when you think of patient safety, and having people that know the system, know how it works, it's really essential. And they've been able to show in other jurisdictions where turnover of staff has led to patient safety incidents and a higher level of patient mortalities. How do you celebrate that sort of expertise? I know you mentioned that you make them champions, but are there other things you do?
Whenever you have any new employee getting into the department, you have to think about safety. So the basic training and what they can do, what they cannot do, and what they can do under supervision, this sets it. Because that is very important when you have to take care of the patient safety. Clear guidelines that these are things, these are high risk things. So the competency assessment becomes important for all these new staff. I was running the HR department also for more than 25 years. We try to motivate them to get on with the specific culture of the organization. That is very important for us, retaining the culture. We have those type of gatekeepers in each department. Now I have a gatekeeper for every department. They are more than 10 years old. Minimum is 10 years. So these are the people who maintain the culture within the department. They understand what has to be done as on patient safety. And when a new employee can be given without supervision, their own responsibility, all these things matter. This giving rewards and recognition. So we ask them to identify champions within their own departments. So it is the work of the top leadership in each department to identify how the team has performed. And every month we give them some recognition or reward. It's all very small. It's not a huge reward or anything, but this recognition keeps them motivated. We try to involve them in every quality program or safety program. It can be a laboratory, it can be a dialysis department. We run various patient safety projects. So we try to involve them in every project like this so that they feel that they are important. That is the first thing you may have to make a person understand. So regarding human resource, I'll go on and on because it is my favorite subject. Understanding a human is really tough. Making them do it according to whatever you need is really tough. So this behavioral change is what we keep on working with various types of measures. It can be psychological, it can be sometimes disciplining is also needed. But most of the times it can be better they take it on themselves to do that project.
When you talk about creating that culture of learning in the hospital, and you've touched on one or two things there, but is there anything else that you do that helps create that culture and sustain it?
Yes. So creating a culture is difficult and more difficult is sustaining it. Sustaining it starts with the top leadership. So you have to walk the talk. So that's what you have given me as a topic also.
Yeah.
So whatever I tell them, I start doing it. So when they see you doing it on the ground level, you tell them to switch off the cell phone while talking to a patient or keeping a privacy, giving the privacy what the patient needs, those 10 minutes or 20 minutes. So these are small things which people start emulating. You have to do it and show it to them. It's very similar to what we need to do to our own children. So the way they see us and it gets reflected in their own habits. So that's why we set the culture. The second way is anything which goes wrong. We sit and discuss and then try to make it right. We try to strengthen the process. We are still working on it since it's an evolving learning health system. But we try not to pinpoint the person behind it. We try to strengthen the process. Either we create a checklist or we create a specific policy. I can give you an example, which I did just yesterday. I was just walking into the hospital and I saw some junior technician trying to draw blood for a child. So it is a difficult procedure. The child is crying and all that.
Yeah.
And the parents are more agitated seeing the child crying. And trying to draw blood becomes a difficult task. We change the whole policy that it has to be in a specific room where you have another 2 or 3 technicians there and the senior most technician has to draw blood. It has to be done under supervision. So we have created a new policy now so that all these are the learning things what we do. We take it from the feedback from the patients or from a complaint and then we start doing it. For the rewards and recognition, we have a program which is a part of this learning health system. So what we do is, when I started seeing, it was in way back 15 years ago. It was in 2000 to 2012. A hospital was just evolving on the intensive care unit. So since we are at the periphery, we are not in a place in a metro. So it's partly a rural semi-urban area. So we don't have that type of intensivists working within the organization. So we had to take a tele-ICU unit. We ran a tele-ICU unit to get the knowledge, know-how. We trained our employees to do it. From 2010 to 2012, I started checking the data. When we looked at the data, we had a CPR, the code blue calls. So the code blue calls were in the wards too. Though it is a small hospital, we did see many of the code blue calls happening in the wards. So I wanted to do something to reduce the code blue calls happening in the wards. So we understood that the code blue calls are allowed intensive care unit or in the emergency room unit or in the dialysis department, because again, dialysis is a chronic disease and you will have emergencies happening. So this is the way we collected the data first. Then we decided that we need to change the system. Then we implemented a new project, which is called the early warning score. This early warning score was available in UK and other countries. We designed our own early warning score. It is very simple. It's a single page, which our nurses will be able to follow it. So it is on a color coding. So we gave it as red, yellow, and green, the traffic signal color.
Yes.
So when they monitor, whenever something is in green, they can continue monitoring. The nurses are allowed to monitor. When something comes up in yellow, the first thing is they have to immediately inform the medical officer, the doctor who is practicing there, and he has to come and see the patient immediately and decide whether the patient has to be shifted to a more intensive care or whatever is the need of the hour. So that is the yellow. And when it comes to red, it becomes code blue.
Okay.
So we started training the doctors and the nurses. We implemented in 2013 and 14. We have completely reduced the code blue calls in the wards. It's nearly at zero now.
Wow.
Every month, we check what was the code blue calls, how the nurses have identified early signal now. Because there is usually a time between the patient being normal and suddenly collapsing. So that is the time when the nurse has to get the patient. So she has to identify it. So whenever a patient is being identified by a nurse, we immediately recognize them in the monthly meeting.
Wow.
It can be a electrolyte imbalance, or it can be a slight neurological problem with the patient, some slurring of speech or whatever it is. They are able to immediately identify it, which none of your monitors will be able to do so fast. So because these patients are in the wards, we don't have a continuous monitoring in the wards. So only with the nurses, we are able to do this. And that's how we have been able to maintain it at zero code blue calls in the wards. So the practice has changed. We have evolved the whole process. So we give them a recognition, give them a badge, which is called the Patient Safety Champion badge, which they wear it proudly. These are some of the ways we try to motivate them.
I love that. I also love that it's one page. That's fantastic. It's great. Yeah.
That is one thing. You were talking about one page. You have to make it as simple as possible for the documentation part, so that they're able to take care of the patient, because the patient care otherwise suffers if you're more into documentation and all that.
Yes.
So we keep it as minimal as possible, whichever is legal, which is really required. And then we move on all these new projects.
Okay. There's a lot to be said for that, because sometimes it seems like there's a different form for every single condition or every single complaint, and with one patient and one nurse or one doctor. So there's something about keeping it manageable. And you've talked there about adapting a global best practice to your context. Are there other examples that you have of adapting global initiatives that you've seen and bringing them to life within your own area?
Yes, this globalization is across the world now. So globalization is in every field, be it technology or healthcare or whatever it is, in every business. So healthcare also, you do have this globalization. This globalization helps us to understand what is happening in other countries. And we try to get the best practices, because it is very important for LMIC specifically, because we are already resource constrained, and repeating it will take so much of time.
Yes.
So whatever is available out there, we try to take it up and then design it according to the local context, and then we start adapting it. Sustaining any project is also important in all this. So you just cannot just adopt it and then leave it out when you go on to the next project.
Yes.
So the way we adapted it, I tried to implement it in my own hospital first. I did it as a pilot. It was during COVID 2019 to 20. We did it as a collaborative project with 9 other hospitals, so that whatever we learn, we start implementing to other hospitals. So it was a QI collaborative where we were able to do it in 2 PDSA cycles, plan, do, study, act cycles, and they were able to implement that project, they implement the paper, the safe childbirth checklist, because that becomes more important in maternal care. You see the surgical safety checklist. It happens in one place. Happens only in the theatre. Whereas childbirth checklist happens at various points. There are various touch points for the patient. So as the patient enters the organization, then in the labor room, and then outside the labor room, and during discharge. So we have various teams. So learning health system has to take care of the safety first. So that's why we trained our nurses, and then we have been seeing that it has been implemented at more than 90 to 100%, even after 4 or 5 years now.
Wow.
All that becomes important. For that also, we have some tools, which one of the tools which we have adopted from Harvard is called the context assessment tool. We call it a CAT.
Okay.
So this important whenever you are starting a project or when you want to sustain a project. So the readiness of our organization to take up new projects, the readiness on basis of the leadership or the commitment or the teamwork or the resources, the culture within the team, all this you are able to find out with this tool where you have a survey for the leadership and for the staff. And based on the survey findings, we create action plans with the team. And that helps us to sustain these type of projects. I've been implementing this context assessment tool for various projects now, be it in our own hospital or in public hospitals. 3 or 4 projects we have taken for the public hospitals, for the government hospitals here, on maternal safety. So this tool has helped us to move it forward.
I really like that idea of having a tool, because I think sometimes if you're taking something from a different area, it doesn't take account of your culture. It doesn't take account of the resources that you have or don't have, or the geographic location. So having that context assessment tool, that sounds like a really useful thing to be able to adapt and apply to your own area. Talking about tools and resources, data is obviously very important for learning. How do you make data useful? Not something that you just collect for the fun of it, but something that can be truly actionable.
Yes. As you say, it has to be actionable. So it's not important that you just collect the data. It is about understanding the data, analyzing the data, getting some information from the data, then creating as a knowledge, and then it moves to the action point. So this is a cycle. This helps you. The data is the thing which guides you to move it forward. It can be from a patient feedback or from a nurse's notes or whatever it is. So it helps you to close the loop of collecting, analyzing, acting, and then again measuring, remeasuring what you have done, whether you have moved forward. So this makes your own learning health system more strong now. This data, the experience with the data is what which distinguishes a learning health system. Every organization, as you say, everyone collects data. So everyone has some data or something. They collect, they adopt, and they apply this evidence into their own system so that the system starts improving. As I was talking to you about the code blue cons.
Yes.
So this is an example of how you have analyzed your own data and use the data to change a process and then remeasure it. So we have been measuring it all these years to consistently keep it at a safer level. So this is the way a learning system evolves.
And I really like that idea of sustaining it, because it is very often we do quality improvement work and it is somebody moves roles or they get promoted after they've done that beautiful piece of work and then they're gone. But how does it sustain in the system? So being able to have that loop, that learning health system, as you've said, makes a difference. Do you think the learning health system supports innovation?
Yes, because innovation is one thing which drives the healthcare system forward. So it helps you to evolve and also adapt, because there are so much of huge changes occurring in our healthcare because it's so complex. It's so driven now with AI, with pandemics and all that. Only when you start evolving, you'll be more resilient as an organization, and only with innovation this happens. So innovation will become the driver to transform your own organization. And so we call it as the innovation spiral, where each and every moment of that innovation, you learn and adapt it. This innovation spiral has 4 or 5 steps where you are identifying a specific problem and then you co-create a solution based on the problem with your own team. And then you test and refine the whole issue and then you implement and spread it again. So this example, which I am going to tell you, is a perfect example for innovation spiral, which we did during the COVID pandemic. So during the COVID, hospitals started facing an acute shortage of N95 masks.
Yes.
So it was very costly and none of us were ready to face that challenge. So N95 mask, it was very costly to get it for our own staff safety. So I wanted to help our staff because we didn't want any of our staff members to get into any issues. So the plan was I started sitting because it was a complete lockdown at that point of time in India.
Yes.
I started thinking what we can do to help people out. So immediately what we did was we were running out of COVID-95 masks. I took the help of 2 or 3 technicians, biomedical engineers, IT people, engineers who are into physics and other things. And so then we sat and created a box, stainless steel box, to reuse the N95 after sterilization.
Wow.
So we created ultraviolet sterilization box. But to get the formula right, we had to work through it because we needed to find the number of UV lamps which is required to sterilize it, and what is the distance between the UV lamp and the N95 mask, and how long to sterilize it. So all these things had to be verified. That too, it was in the lockdown period. So we had to work our own process, get it right, and then we had to test it now. So testing it since we didn't have COVID-19 virus at that point of time.
Yes.
So we had bacteria and other organisms. So we were testing it, did microbiological culture for 5 minutes, 10 minutes, 15 minutes, half an hour, so that we were able to understand at what point of time it was being sterilized, and then we will be able to reuse it. Because when I went through all the papers, all the Western countries were talking about a huge room with the UV light or hydrogen peroxide for reusing it. But their reuse was, it can be given to any other employee.
Yes. Okay.
It is very difficult to reuse a mask which has been used by someone else. So what I did was we identified the name of the employee and we created a process of a red color bag and a green color bag where when it is brought to sterilization, it will be given in a red color bag, and after sterilization, will be put in the name of the employee and in the green color bag. So the whole process was defined and we were using it for 1 year. So you can reuse it for nearly 25 times. That was the number of times also we measured with the testing process. That helped us to continue that. At the end of it, when we were testing it, the implementation part, we were able to see the process was implemented and none of our employees got COVID because of the working inside the organization.
Wow. Okay. That's phenomenal.
This is the way the innovation spiral works. And we are trying to get it into a paper and we have applied for a patent also for that thing, but it is time consuming, all these type of work. So it's still on a process now.
It's very time consuming, but really important. And can I ask, how do you involve patients and families in the learning health system?
Yes. So this is very important because all of us are working only for the patients and families. So you need to involve them, keep them at the center of whatever you're going to change any process. It has to become a person-centered care. I've been working on this person-centered care principles for many years now because taking them as not as simple passive people, we are taking them as active partners for their own care. So for that, the empowerment is important. You have to get them to the literacy level and then you engage them. So this empowerment and engagement of patients and families become important. So that's why we have started running the Patient and Family Centered Advisory Council within our own hospital where we co-design various projects. We call it as experience-based co-design. It's called EBCD. We have designed projects in dialysis and pharmacies. We talk about patient journeys, the experience of a patient when they walk into a hospital. So based on all this, we were able to improve on it. But what we have specifically tried with innovation in this patient empowerment and engagement was we started creating digital technologies now to help patients to understand their own issues. So we have various apps. We have 7 or 8 apps now. Certain things are integrated within our own workflows. Certain things are standalone because it is only for the patients to understand. We have taken the help of Noora Health. It's called the Noora Health app, where they send it in a local in the local language, because this local language is very important in LMICs. You need to understand the culture of the patient and the families. So for maternal health, we have taken the help of Noora Health app, where the patients, as soon as we put the last menstrual period date, so every month the patient receives a message on their own WhatsApp. It is simple and it's very cost effective. It's free of charge basically. So the patient starts understanding what are the emergency symptoms for what they have to come into the hospital, what are the tests which has to be done. All these things can be for eclampsia, it can be for fever. All these are simple and important things during maternal health. It helps them through the delivery and after postnatal also, after the delivery, till contraception and everything. It also works for the non-communicable diseases because India is a huge country with highest number of diabetic population now. We keep on working in various camps. We do various free camps from our organization in all the villages. These apps have helped the patients to understand their own issues. So we have another app called the Apollo Pro Health app. It is very proactive and patient friendly. So even when we are doing under a tree, we just do the camps there. We just do the blood testing to make them understand whether they are diabetic or non-diabetic. So this app, when you put all their details in the app, it gives you a score. The score helps you to understand what is the risk to develop diabetes complications, what is the risk of cardiac complications. And based on the score, you are able to advise the patient then and there. This helps to improve the complaints. The patient themselves start understanding what are the risks.
What do they need to watch for?
They want to reduce the score along with you. So these are some of the ways we have involved the patients' families in their own engagement of all these issues.
Okay. You'd mentioned when you're out in the communities, how important do you think it is to be outside of the hospital to influence community change or community health behaviours?
Yes, this is very important as community health behavior is important. And as doctors, we have been doing these type of camps for more than 25 years now.
Okay.
So every week, every Sunday, our team goes and visits one village and just make them understand what is diabetes, what are the non-communicable diseases. We are just into training them and teaching them. That is the most important thing which you have to do.
Okay.
The treatment part is later. But when you get into the community, the trust improves. So the patient knows that the trust of the patient starts improving with the doctor. They know that we are there for them. And so we have been taking the help of many NGO organizations. Whoever wants to do any camp with us, we are there. So this has been a continuous program last 2 decades now. We have been evolving these projects also. So the earlier camps, when we started doing in 2000 and 2001, the literacy was very low in the villages. So if I tell them this and that, they'll not be able to understand. So we started taking the help of making a model using drawings, making them engage in all those drawings.
Yeah.
Then we created some exhibitions, food exhibitions, so that the people will understand what to eat and what not to eat. And we try to fill up the what to eat column more now.
Okay.
As soon as you give a diagnosis of diabetes or any other issues,
What can I eat?
so what I eat.
Yes.
So we try to make them understand that there are so many things that you can eat in spite of diabetes. You can have healthy food choices. And so we started having these type of diet exhibitions. And then as we slowly evolved, we started doing puppet shows. So this puppet shows are very innovative. It's all life-size puppets, not those small hand puppets.
Oh, I love it.
Those puppets are 6 feet in height. And what we have done is we take these puppets. Issue is taking all this into the village and getting them back. So these are some of the challenges which we still face because we have to take our own ambulance to do that because we don't have a vehicle to give it entirely for these type of camps. But all these 20 years, we have taught our own staff in the diabetic department to do these puppets, which are life-size puppets. And the puppets themselves talk about diabetes.
Okay.
So we have done all these as film songs. In India, the film songs is a huge craze. We have so many heroes and heroines here,
Yes.
the actors.
Yeah.
The songs are a huge craze, more than the movies. So we took the help of those songs. We converted everything to awareness and education on diabetes and other things. And these puppet shows are a huge hit. So everyone comes and starts watching in a village, or it can be in a school. We teach about healthy living for the school students. So these are some of the ways where we have evolved this, and now it has moved on to the digital platform. So the last 20 years, it has been like this, and now we are using the digital platform for our own village patients, where everyone has a cell phone and everyone has a WhatsApp. So now we are trying to take that up, and that's how these type of newer digital platforms, these Noura Health app or other platforms help us. The program is called the Care Companion Program, where we are trying to engage the families who are involved in the care.
Okay.
Because this also is quite different from HIC. In LMIC, when you see any patient, you always treat a family, not a single patient. Because the whole family comes into the hospital. So you have all the parents, grandparents. For a delivery, you will have 10 or 15 people waiting outside.
Oh, wow. Okay.
So this is the way our hospitals work. You need to involve the families in all the decision making. So this is the way it works. And so the cultural and context specificity is very important. You have to take care of it when you're talking about a learning health system. And that's why this context-specific things help us to sustain all these practices.
Yeah. And I love that idea that the system includes the families, because it is that sort of broader community piece. And often, I know myself, when I was pregnant, it might have been a family member might have said something. Have you asked that question? Or did you think about this? It is that piece that you might not necessarily know yourself, but you have others around you. And I love the idea of the puppet.
Yeah, it is not easy to make that puppet. It is on a stick. The size is 6 feet height, so that even 100 people or 200 people audience can visualize it at a distance.
Yeah.
And this, it was made by a specific person who was into this, and he has got a President Award doing this actually.
Uh-huh.
So we took the help of him and we designed it completely for our own healthcare needs. And now it is huge hit among the children specifically. So we can make the puppet talk in any language, any form. So we have recorded things. We have 3 things specifically. One which talks about diabetes, then talking about complications of diabetes. We have a 3rd session for students now, so that they understand what are the healthy foods to eat. So the cabbage comes and talks to them. The brinjal comes and talks to them.
Yeah. It sticks. There is something about that creative piece of humanity where sometimes it captures our imagination in a different way. You've talked there about that span of the work that you've done. What have been the biggest challenges in sustaining your learning health system work over time? How have you overcome them?
Yes, always is building a learning health system. That is a huge challenge. So it is not a one-time effort what we are going to talk about. It is a continuous journey. So that's why I'm talking about the 3 decades of change what we have done at the system.
Yeah.
The first start might be energizing. You will face so many roadblocks along the way. It can be because of the resources or the staff turnover or understanding the data what you have. So there are so many issues. We try to take every challenge as a learning opportunity and try to move around it, work around it, so that we start evolving as a proper learning health system. We have these orientation programs because staff turnover used to be very high because we are away from a metro, as I told you. So people try to move into a metro for better future and their own plans. So creating a conducive environment is very important when you want to retain your employees. So that part of it, we tell them that it is your department and you try to change whatever you want. We'll be there to support you.
Yes.
They take the accountability for their own department, and be it day or night, they are so close with the department people, and that's how this all works. There are huge gaps, and sometimes when you collect the data, so for that, we have started digitalizing certain things so that you have the data. We have used certain technology like QR codes. So QR codes are across the hospital now. So based on the QR codes, we are able to see real-time data as feedback from the patients or from the staff. And again, you evolve the system based on that. We take care of the resource constraints where we try to take only simple things which are not huge resource burden. Because only if you take simpler things, you'll be able to sustain it. Otherwise, it will fall flat because you don't have funding for all this.
Yes.
All these are sparks of creativity. So more of creativity, then you understand how to evolve it. And then these are all challenges which help you to strengthen the whole process and strengthen the systems. So as I told you, some of the tools also help you to sustain all these projects. That way you'll be able to sustain the whole system. And it is basically the culture which matters. The culture of the organization, the mindset with the leader's ability, that changes the whole system into a learning health system.
And speaking of leadership, your leadership is recognized internationally. What leadership style do you think is important to help nurture this type of a culture?
Yes. So as I told you, the leadership style, there are various leadership styles. And as a leader, I myself, I evolved over the years. The first 10 years was different, second 10 years was different, and the third decade has been different.
Yeah.
So now we try to take them because you're also evolving as a leader.
Learning.
You're learning as a leader.
Yeah.
You learn from the staff. You learn from everyone. So this evolving, being more flexible is very important. And you have to walk the talk. You have to lead by example. And it should be a collaborative leadership. Take your team into your group. Every voice in that group matters. So it can be the newest employee or it can be the senior person. We ask them, even if they have worked somewhere else, we ask them if they have some better practices where we can adapt into our own system. So we give them some clarity, we give them courage to tell, the compassion is important. So all these help you to improve the whole system. And when you think of a leader, the leader has to take the responsibility. So here the person has to take complete responsibility, and you have to share the recognition with your own team, and you have to be willing to be more accountable. So these are three things which help you to evolve as a leader. So the employees also get more motivated, and we build trust and courage within the system. We are trying to make it as a continuous improvement learning system where they also learn and they also move forward. And every time we ask them to learn something new, any staff who has learned something new, we give them recognition again. Learning is very important for me. I learn and I ask them also to learn. So this is the way it goes on.
I love that. I love that explanation. And if I was to ask you if you had advice for somebody starting off on that journey, what advice would you give them?
Since we are itself into an evolving system, I will not be able to give you the perfect advice. But whatever we have experienced, I can let you know so that people who are getting onto this will be able to move it forward.
Yeah.
So no health system can change overnight. It is a huge process because you have to get the culture right.
Yes.
After getting a culture, then you have to keep on sustaining that culture. That becomes important. And sustaining it, you have to think of each and every process. It should not be dependent on a single person, a single individual, because individual will move. So getting the culture right is what the leadership has to do. So you have to have various cadres who are trying to talk about that leadership culture. So I tell them that you are all there for my sake, and you are going to talk about the culture of patient safety whenever I'm not there. So they have taken it on themselves and they now start talking about it. So it is a journey where it is anchored on a strong leadership, and you have to start using the data which is available at the bedside. You don't need a huge amount of data or technology, whatever it is. Whatever data is available, you start understanding the data and analyze it and improve on the data. And again, the culture of every workforce is important, so you have to get them onto that culture. You will be able to understand the learning health system because this becomes a more safer system. Because learning health system ensures that your care is becoming safer tomorrow because it's going to learn from what has happened today. I can give you 3 takeaways for any system to improve. So first is you start very small. Start now, but start it small so that you are able to change and evolve a single process. It can be a single process within your department or whatever it is. So you just test the change and see whether it has improved it. So that is starting it. And then you listen to your employees before starting a project. Listen to the stakeholders so that you hear your teams, understand the challenges, understand the difficulty, and then you work around them. Otherwise, if you're just going to give them some project to do it, no one will do it and it will fall flat.
Yes.
Third one, keep it as human as possible because you are talking about patients. So the person-centered care becomes important. So you are going to talk about the people, the stories, their experience. So to make the safer experience and safer care for tomorrow, you start to listen to them and then you learn and then you are able to save lives. So this is what learning system is about.
I think that's really, really wonderful advice. You've influenced patient safety and quality at hospital, national, and even international levels. How did this journey evolve from leading change within your own hospital to working on global platforms? And along the way, how did these experiences shape and deepen your understanding of learning health systems?
Thank you, Juanita, for asking that because it really makes me to pause and reflect my own journey the last 3 decades now. And as you know, my leadership journey didn't start with a very grand plan. It was very simple to make care safer for our own patients who trusted us. And so everything grew from that one intention within the hospital. So in the early days when we started the hospital, Sriranga Hospital, it was way back in 1992. I was deeply focused on how we are going to deliver the care to our community. So we started implementing various quality standards in every department because that makes it more easier for us to run the organization. And we started implementing patient safety practices and we learned each and every day from our own outcomes.
Yeah.
So this experience helped me to understand how a structured improvement can be done and how we have to learn. There are so much to learn. And again, I started teaching and mentoring students, and that is another way to start learning and sharing whatever we have. All these practices of local learning. So it slowly started moving out of our own hospital walls. Yeah, it started moving and then globally. So the first major turning point outside my hospital was the start of my working with CAHO. CAHO is CAHO, it's Consortium of Accredited Healthcare Organization. which works in India. So it is for quality, patient safety, and accreditation. So I started getting interested in Kaho because it was very much aligned to what I was believing in, improving patient safety at the ground level.
Yes.
So we started working with them in 2017. And so I started as a representation within our own state and then slowly moved on to the national level. So now I'm the chair of the quality professions wing of Kaho at the national level. In Kaho, we have designed various modules, built capacity, done various programs. This is where truly my work started amplifying beyond the hospital walls. And I've been always grateful to the leadership of Kaho, which includes Dr. Vijay Agarwal and Dr. Lalu Joseph. They trusted in me and they gave me the confidence to grow, and also they gave me the platform to lead. So that was the first opportunity for me to start it out. And then the next turning point came out as I became an assessor to started doing audits, the quality standards which were from the national board. It's called the NABH, the National Accreditation Board for Hospitals. So we have what is called the NABH in India. So I started traveling across the country now, visiting small hospitals, large academic centers, and it has been a great learning because it helped me to broaden my perspective, and every assessment became a learning opportunity. So I brought these insights back to my own hospital and also started sharing my own thinking. And this was a continuous learning and adapting. And this helped us to grow as a learning health system again.
Yes.
We started moving into the global stage, and that was through ISQA. ISQA is the International Society for Quality in Healthcare, based out of Dublin. And this journey started way back in 2019, 18 to 19. So I was there for a conference in Malaysia, and that's how I started understanding about ISQA. And I wanted to initiate a collaboration between Kaho and ISQA, and I did it. And that's how ISQA was brought into India. So these last few years has been a great learning for all of us in India, because we are able to understand what is the learning from the other systems now. We have various learning platforms which we share with ISQA, and the credibility and trust between these two organizations have grown in a huge level. This collaboration has helped us in many ways, and this has improved the learning health system again.
It's wonderful.
Moving on, within ISQA, I became an academy member, and then now I've been elected into the ISQA board. So I've been nominated into the ISQA board, and this has allowed me to understand various lessons as a LMIC. So this LMIC context, including it into the global lessons, this has been a great learning again. This has helped me to amplify my voice beyond borders now. It has helped me to advocate various global frameworks. So because these frameworks has to be adaptable and it has to be contextualized to the local needs. This has helped me to create a new leader paper now. It is a ISQA white paper on patient safety. And it has helped me to be the lead author to write this paper with various experts across the globe now. All these have improved the learning.
Yes.
I've been parallelly working with the ASPA, the Asian Society for Quality in Healthcare, and I'm serving as a board member there. And I run various committees there. And again, it has helped us to share experiences and get feedback from other countries, like-minded countries. It is more on the local context in Asia. But one of the most defining moments, which I should say in my journey, is my collaboration with the Harvard T.H. Chan School of Public Health in US. I think you will know the Ariadne labs, which are there, part of the Harvard School, that showed me how disciplined learning cycles are, how to context adapt and share data, which will help us to improve scale and have a big impact across settings.
Yes.
I was part of various quality collaborators with Ariadne Labs, and this has helped me to transform the local learning into a collective knowledge now. I was able to complete the Global Health Delivery Intensive course at Harvard, and this also strengthened my perspective. And again, now as an associate faculty with Harvard, I'm able to contribute to the research, to various publications, and with various quality improvement projects. I do it in India. For all this, I'm always grateful to the Ariadne leadership, Dr. Catherine Semero, for the mentorship and also the trust which she has had in running these projects now. And even now, I'm collaborating with them through ISQA, through the International Society, through Kaho, from India, and across borders now. So as I look back on this journey, I don't see any straight path. Learning has helped me to go on sharing. And this sharing has helped me to build trust. And again, this trust has helped me to create opportunities, learn from it. It was started first within my hospital and then across India and then across the world. And this has been done only with various mentors and teachers. And I'm always grateful to all of them in my learning journey.
I know anybody that's listening will be thinking, wow, and where do you start? If anyone did one of those things, it would be phenomenal. But to do all of them simultaneously and continuing to build that leadership globally is phenomenal. My question is, did leadership come naturally to you, or did it grow over time as you learned more about learning health systems and improvement?
To give you an honest answer, it was a no, because leadership wasn't very natural to me. I was never a leader in school or college. I was quite the shy person and rarely the one to step forward for anything. So, whatever leadership I have today exists because of the people who believed in me at the right moment. So, I've been always fortunate to have the steady support of my parents and my in laws, and especially my husband, who always has been encouraging me and walking beside me through every phase of my life. And also my children, because they are all grown up now, but they have understood and supported the work I do. So there were times when I felt it was real challenging, because I work in a periphery hospital in a developing country, and I'm still trying to contribute to a global movement in patient safety across the world. So there were times which has been a huge challenge. What has carried me through was the learning from my patients, the learning from the data, learning from mistakes, and also learning from working together as a team. So that's what a learning health system taught me. Leadership is always not about getting all the answers right. It's always about willing to learn every day. I truly believe that leadership is not about any titles. I always believe on the 3 core C's. I call them as the C core values: the courage, the consistency, and the compassion.
I love that.
Yeah. And as women, when we have all these 3 C's, we always don't just improve systems. We would transform care for the generations to come. So that's how I see the leadership and the way we transform the learning health systems, which has to evolve.
That's really beautiful. Thank you so much for that. And thank you so much again for your time.
I enjoyed the conversation. Thank you.
As we come to the end of this episode of the Walk and Talk Improvement podcast, we would like to thank Dr. Anu for sharing her wisdom and experience so willingly. It has been such a privilege to speak with her on this topic. For you as a listener, we hope that Dr. Anu's insights will continue to inspire you in your work to improve health and social care services. We hope you enjoyed this episode. And if you would like to hear more content like this, you can listen to the Walk and Talk Improvement podcast wherever you get your podcasts. Thank you for listening.